But I'd like to welcome today Joel Cantor and Jose Nova. Joel is the director of the Center for State Health Policy here at the Institute for Health, and Jose is the associate director of data and analytics for the Center for State Health Policy. They'll be discussing integrated data for population health research, the New Jersey iPHD project. So I will hand it over to Joel, and I'll just mention if anybody has any questions throughout the presentation, feel free to drop them in the chat and we can discuss them after the presentation.
Great. Thanks, Nicole. I'll start and then hand things over to Jose. And thanks everybody for joining us today. Pardon me. Let's see. So the plan for the day is this. I know not everybody on the call is familiar with the Integrated Population Health Data Project, so I'll quickly go through that, especially talking about the things researchers care about most. What are the research priorities, the data sources? We'll talk about our data linkage strategy, which is sort of new information and a work in progress. I'll give a quick recap of our first cycle of grants and approved projects, which we just announced. Talk about the current cycle, a little bit about how to apply and the focus there. And then I'm really looking forward to a discussion of with this group, and questions, can answer any questions you have, but I especially want to focus on your ideas about how to improve the value of the iPHD for research and at the same time improve our sustainability. So of course, always start with the acknowledgements, and in this case, there's a lot of them. It takes several villages to get this project done. The center staff, I especially want to acknowledge, this has been an enormous amount of work to stand this up. Their names are listed there. I won't go through them all, but everybody has played a really integral part in making this work. As I'll describe, the iPHD project has a governing process and a governing board, and we have an incredibly dedicated group of governing board members chaired by Rachel Hammond, who is the privacy officer at the New Jersey Department of Health and is the chairs our board, and as well as the data stewards for each of the data sets in here. This has not been a trivial amount of work for them. We will hear more about ChoiceMaker and the linkage process. There are partners and advisors on data linkage. They are on, some of them are on the call and could be available to answer questions at the end if Jose and I can't cover them. And finally, of course, funding credit. We have had resources from the New Jersey Department of Health supplemented with Robert Wood Johnson Foundation funds. So first, an overview of the iPHD. It was established in legislation in 2016 with the following purpose. It creates a process for integrating data across publicly supported programs in New Jersey for the purpose of advancing population health research. And the specific sub-bullets there are the things that we're authorized in the legislation to study. Strategies to improve public health, safety, security, and well-being of New Jersey residents, and the cost efficiency of governmental assistance programs. Nothing to argue with there. Those are lofty goals. The law establishes a governing board and a governance process. It authorizes the operation of the iPHD within the Center for State Health Policy, which of course is a unit of the Institute for Health. And not in the law, but subsequent to it, we have received the support from DOH for startup, the financial support. But the expectation of the law is that this becomes self-supporting over time with fees and grants, and we'll talk more about that. So all these details and more is available on the iPHD website, iphd.rutgers.edu. You'll see that several times as we proceed. So here's our governing board. There ex officio members who represent appointed by their commissioners and representing departments. Those with the, I guess it's purple or blue roles in them are public members appointed by the governor's office or leadership in the Assembly and the Senate with very specific perspectives to bring to the board, as you can see there. Just want to call out Michelle Noren, from our CIO at Rutgers, is also a member of the board, as am I, although I don't get to vote. But I get to participate. So I'm going to turn, let's see, was it this one, Jose? Let me do this one and then I'll turn it over to you. So these are our research priorities and that have been endorsed by the board. Addressing the opioid epidemic, addressing improving maternal and infant health, addressing social determinants of health with a special emphasis on integration of behavioral health and physical health services, but not exclusively. It's very broad. And then lastly, COVID-19 and other public health emergencies. These are intentionally written very broadly, and I think would cover, for those of you I know on the call, could cover everything you do. So it's a very nice set of priorities. They clearly reflect the public health issues, the population health concerns in New Jersey. So now I'm going to turn over the microphone to Jose to kind of walk through the data and the data linkage work.
Very much, Joel. So yes, I'll start by talking about some of our current data holdings. So the data sources that are currently contained within the iPHD, and currently all of these are from the Department of Health, but we're looking to expand that as we move forward. So some of these data sources you may or may not be familiar with, and they include the mortality data, and this includes immediate, intermediate, and underlying causes of death, as well as demographic attributes of deceased, place of death. And these records are for New Jersey residents, regardless of location of death. Also included are the New Jersey birth records, which is a standardized electronic birth file that contains data elements such as setting and date and time of delivery, as well as health and demographic attributes of the newborn and the mother. We also have the all-payer hospital uniform billing records, which is hospital claims data from inpatient discharges and in-person visits made to hospital emergency and outpatient departments at New Jersey hospitals. Some of the data elements include, but are not limited to, admission and discharge dates, encounter information, such as diagnosis, patient characteristics, and associated charges for the visit. We also have the NJ COVID-19 surveillance data. So this comes from the New Jersey Communicable Disease Reporting and Surveillance System. So this is COVID-19 related data, so essentially PCR tests. So some of the data elements include dates of illness onset, lab results, and other relevant information collected from public health partners statewide, including local health departments. And we are also, for this second cycle, looking to include New Jersey Medical Services data. And this data details EMS responses to calls throughout New Jersey. And some of the data elements contained here include location, incident dates and time, type of transport, whether it was by ambulance or helicopter, any relevant medical history, and procedures that are delivered by the dispatched medical response team at the time. So as you can see on the chart, those are the current years, and we're looking to update these as they become available. Some of these have longer lag times than others, but as soon as they are available and finalized on the DOH side, then they get transferred over to our end. Next slide. Some additional sources that are being discussed by the governing board include COVID-19 vaccination registry data, and also the New Jersey enrollment claims and encounter data, which would only enrich our current holdings. Next slide, please. Okay, so before I talk about data linkage, I do want to sort of talk about the pre-linkage process. And again, I do want to re-acknowledge the work that Rick Hall has provided from ChoiceMaker in configuring and setting up the data linkage models for this project. I'd also like to acknowledge the support from the iPHD computing team, which have been working hand in hand. So particularly Jonathan, Sam, Dinesh, and John DeBulo, who put in a lot of work in setting up the isolated environment, transferring of files and configuration. I'm sure they're sick of me. I'm always bugging them with requests, and they've been extremely helpful throughout the process. So as I said before, the actual data linkage and record matching happens, there is this pre-data linkage process that happens, which is the ETL process. So we receive the files from the data stewards, they're sent to us, and what we do is we preserve this raw source data file that is untouched. So we set those aside. We bring in any documentation that are sent by the data stewards, and we do a data contents and run some descriptives. Next, we begin to prepare the files. So we sort of pull out that source file, and we begin to add some metadata for our end. And that really describes the data set so that we can manage those files. That includes sort of the data source name, the year of record, and things of that nature. We also generate a universal unique record ID. So this is particular to one row in a giant table. So it's a unique record so that we can track where that record goes and are able to link back to that record throughout the data matching process. Another crucial step is sort of the next step in where we have to create a stacked table, which where we have to standardize and really normalize a lot of these identifiers. So these data sources, as I mentioned before, are coming from different types of data. So the fields are not named the same. And even within a data source, there are layout changes. So some of our data goes back to the year 2000 up to present. Throughout that time, there has been some changes to those files. So we have to bring that in, standardize each of those fields so that they can line up. So first name, last name, dates of birth, all of that has to be in a standardized format so they can essentially stack into one file. During that process, we also developed some derived and computing fields. So some examples of a derived field is a soundex, which is a coded index that it's based on the way a name sounds rather than the way a name is spelled. And this, as I'll describe later, is important for the data matching process. We also geocode address at the street level wherever possible against census tiger files. And that allows us to sort of bring in latitude and longitude information and sort of a standardized address that we can match against each other. And then finally, the last step here is a deterministic deduplication. Now, we don't do this initially, but it is something that as you go through the process and you start developing a master person index, you can deduplicate the file. That will reduce the amount of matches you have to do in the next steps. Also, if the data source provides a patient identifier that you can trust, that will also allow you to reduce the number of matches that you have to compute. Next slide, please. So this is an overview of the matching that we're doing with using the ChoiceMaker tool. So ChoiceMaker is a Java-based application that runs against a Microsoft SQL database. And we use SAS to do a lot of the data prep and managing the import files that go into database. But then the ChoiceMaker tool will pull the records from a database. So in this first step here, so Joel, if you can just click, yeah, that's where the input files go in that I described earlier. Once they're standardized, either from a master database or another query record that we're adding throughout the process. The next stage is blocking stage, and this is what we would describe as a fast matching algorithm that puts records into blocking groups. And we are blocking on things like first name, last name, name soundex, year and month of birth, and also the reverse of first name and last name. As you know, like the quality of data can vary. So this initial fast matching is sort of, are these records in the ballpark? And this is used to sort of narrow down the number of records that needs to be processed by like a higher precision later on and the more computative intensive stages that happen later on. So some of the analogies for this is sort of, when you do your laundry and you're sort of sorting socks, right? So you put them into different color buckets. So something I have my kids doing. So they usually will sort our socks at that blocking stage. And so my younger one to do that, and then my daughter will come later and with more precision and make sure that the socks line up, which isn't always the case if you see me in the office with mismatching socks. But in any case, that is not happening here. We are matching our socks correctly here. So the next stage is the more intensive decision-making stage, and this is based on a maximum entropy model or a logistic regression. And this stage I will describe it in a little more detail with the following example. So after this stage occurs, you get an output file, which gives you a match probability that really outputs the decision into 3 buckets: a low probability differ decision, medium probability for a human review, and then the match decision, which we think is a high probability the 2 records are matching here. So next slide, please. And this is where you can then develop your common index and create a person ID for records that match. Next slide. So as I mentioned earlier, the ChoiceMaker is built around a set of 50 to 200 clues or features, what they're sometimes called, for match and differ decisions. And these are made on common names, birth dates, address approximations, things like admission dates, indicator of twins. You can use this on medical record IDs if they exist, insurance IDs, and so on. And this is really saying, like, are our first names the same? Are they common names? Are they uncommon? Are they rare names? Do the last names have like the same soundex? And are birth dates different? So the model is trained, it goes through this training process where it looks at a set of pair records that have been tagged as match, differ, or hold. So there is a human component to this where we train the data. So sets of pairs are pulled out and members of our team will look at these records and sort of a subset of records, and we'll make decisions on that. And based on the decisions we make, whether or not they match, that goes back into the ChoiceMaker tools, and essentially we'll learn from this and try to replicate it with the rest of the data set. So this training process then assigns each of the clues a weight, which is a positive real number, indicating the relative predictive strength of the clue, denoted by that formula listed in the bottom. Next slide, please. So this is a very simple example, just so we can get an idea of it. So in this example here, as I mentioned, so we're trying to see if these 2 records for Jim Connor are matches or not. So, and you see the fields that are being used here are first name, last name, and Soundex last name, which I referred to before, which is a phonetic code of the names. So you see that the first names are the same, and the prediction there is it's a match and a weight is assigned. You'll see that the last names, if you're looking at them exactly, they're different, right? They're off by a letter. And then that's a different prediction, and it's assigned a weight. But then you see the Soundex last name where they're similar, and that is a match, and then that is assigned a weight of 5.5. So based on the formula before, which is the match product, and that is match product over the sum of the match product over the different products. And given this example, this formula gives us the probability of 79% that Jim Connor with the E and Jim Connor with an O are the same persons. And as I mentioned, the weights are determined during the training by the engine to produce the decision that is consistent with human markings. And depending on the data sources you have, you can adjust these weights as needed. Next slide, please. So where we are with our matching, so this was our first go around with the initial matching. We have reviewed about 58 million records from our data sources. And this includes about 2.4 million records for birth mothers. So we're evaluating those results and doing more testing before we make a final decision on assigning a master person ID for those that were deemed to be matches. So we'll be creating that master person ID and relevant pseudonymous identifiers or study IDs for limited data sets for the initial 4 study projects. We're also constructing crosswalks for the birth record file to link child and mother. So we'll be able to track a child's mother across the data set as well as the child themselves. We're gonna, like I mentioned, we're gonna continue to improve our matching model as new data is introduced and as we learn more from fields throughout the process. As I mentioned, throughout this, we've learned that, for example, insurance ID could be a good ID to use. Even though you may change insurance, it can allow you, if other things are different and this matches, this may be a match. So we're looking at all sorts of things like that to continue to improve the model. That's it. Back to you, Joel. Thank you.
Thanks, Jose. And I know this was a quick overview, so if folks have questions at the end, we'll be happy to try to address them. I also want to emphasize this is our first time through this process. And we have found that it's continuing the metaphor, it takes a village from our IT team, Jose, Rick, and his colleagues to really work this through, that we're kind of pushing the envelope on the computing resources that we have. All this going on at a time when our computing systems are in transition to another platform. So I won't dwell on that, but I just want to especially thank the team for leaning in so hard and helping us get this important work done. My last point on the data matching linkage process is that we really are committed to transparency in this. We'll be producing documentation. So as folks go to publish their work, they'll have something to cite if journals and reviewers really want to see how the sausage is made. So let me now turn to the next topic, and I'll do this one pretty quickly since it's a little bit of a rearview mirror, and talk about our first application cycle 1 that was conducted last year. And very quickly, this is the timeline. So back in June, we took applications and we had 2 categories. You could apply, one could apply for some pilot grants. There were $40,000 pilot grants. We had 4 available. or you could apply for data only, but then the applicant would have to pay. We wouldn't give you any resources, but you'd have to pay us based on a fee schedule that we develop. So we received applications. We have a formal review process where we have 3 subject matter research and data experts review each application. That then goes to the governing board, and a subcommittee of the board reviews everything and makes a recommendation to the board. The board has final say on what projects are approved. And those, even though I'm on the board, I stay out of that process. Michelle Noren stays out of that process. We have too many conflicts, and we have very strict conflict of interest policies in general, similar to NIH policies on conflicts. The board ultimately made their decisions. Then they handed back to us, where we execute subawards or sub-accounts, depending on whether it's Rutgers or not. We have data use agreements, et cetera, so the paperwork phase, if you will. We're almost all the way through that. For round 1, we're waiting for a few more pieces to get completed. And then we should be able to start pushing out the limited data sets. Our rules are, the statute says that we follow HIPAA minimum necessary rules. So we're producing tailored data sets for each of the approved projects, and expect to get those out in the next 6 weeks or less. So I just wanted to quickly go through the 4 projects that were approved to illustrate what the work that's about to start. So this first one at the Central Jersey Family Health Consortium are looking at the birth outcomes spanning the period of the early period of the pandemic, with a special focus on racial differences. And you can see on the bottom row there which data sets they are using and what periods. Next up at the School of Public Health, our colleagues there are also looking at birth-related cohorts, looking at perinatal depression and use of emergency departments, using birth and hospital discharge data for a pretty long span of time. Third, the Hackensack Meridian School of Medicine, looking at geographic perspective on mental health outcomes and the provision of behavioral health services by the New Jersey Pediatric Psychiatry Collaborative. And again, here using mortality and hospital UB data for this work. And last, and certainly not least, is our colleague Steve Crystal and company at the Institute of Health, examining social vulnerability disparities and health impacts of the dual epidemics of COVID-19 and the opioid epidemic. Really looking across 3 different data sets, employing 3 different data sets in their work. So we have a new cycle up and running, and I'll run through that so you can see where we are, and there's still an opportunity to apply. So we've made some modifications. We're a learning organization, so we've made a lot of changes to our processes, scoring and review process. We greatly expanded our review committee, or it's not a committee, the panel of reviewers, and also based on availability of funding have made some changes. So this cycle, which was opened on March 1st, we expect to be making up to 2 pilot awards. In addition, a new category that we will, the board, would be available for the board to approve are fee waivers. So no pilot grant, but no fees either. Up to 2 of those. I should mention that if one receives pilot funding, the fees are also waived. So pilot funding with fee waiver alone. And then the third category is no grant, no fee waiver. And then the approved applicant would have to pay to receive the data. So the letter of intents are mandatory but not binding. This gives us a sense of the topics, and so we can start arranging reviewers ahead of time. Those are due via email to us, right? I think it's email. It's all on the website there. Those are due March 22nd, so we have a little bit of time left. If you need to pop off and work on your letter, I understand. You can watch the video later. Then the full applications are due by April 26th. There's no selection process with the letters of intent. You can move right into preparing your application, due to us by April 26th via the website. At the stroke of midnight, the portal closes, and those will be the applications we review. So we will then, with each one, we'll calculate the applicable fees that will either be waived or not, and we can communicate that with every applicant. And our aim is to get that out in May. If we get to a dozen and a half applications, it might be quicker. If we get 40 applications, it might take a little longer. And then the review and the board process proceeds with awards announced in November, followed by a period of execution of paperwork and so forth, followed by delivery of data sets. The requests for applications and instructions are on the website. So I have a little bit of an update to provide here, along with my GIF. Okay, so we are in discussions. So that's the 2023 funding cycle that I just described, and that cycle relies on New Jersey Department of Health funds. The funds and fee waivers are only available to New Jersey-based investigative organizations or institutions. But we are presently in conversations with the Robert Wood Johnson Foundation to be part of their national program called Health Data for Action, HD4A. This is an ongoing program that not every year, but periodically seeks to get hard-to-get data into the hands of population health researchers to do good work. It will be a national competitive call for proposals with a variety of novel state-based data sets, not just the iPHD, but including the iPHD. RWJF will fund grants for successful applicants. Plus or minus, we're expecting about 2 awards for New Jersey for iPHD. The foundation will also fund the center to do the data prep, so there'll be no data fees. The grants will be larger than the pilots that we can offer through DOH, 100,000 or perhaps a little more. And no dates are set yet, but probably fall this year. So stay tuned for this. There'll be a dual review process. The scientific review will be handled by the Robert Wood Johnson Foundation. They will make funding decisions, but for the ones that they're willing to fund, it will go through the same governing board review as any other project. And that's a statutory requirement. Only they can vote to release the data. After that, the process will then be the same. So this will be the first time that non-New Jersey-based organizations can apply for funds to use our data. We're excited about this. We hope that it gets us on the national scene a little bit more, and fund some good work to boot. Okay, so Academy Health manages this grant. There's the Health Data for Action link, and then of course we'll announce it on the iPHD site as well. So let me turn to discussion, and I think we'll have a good amount of time for discussion. I have a few questions that I would really like the input from this group on, but really anything we've talked about linkages to the funding process, we are here to answer questions. So before I launch into the specific questions, I just wanted to focus on a couple of challenges that we face on a day-to-day basis in this project. It's fairly costly to operate the iPHD. Our annual budget for operating the project is over $500,000. Maybe that gets a little more efficient over time as we go through the learning process, but it won't. It's always going to be costly, and we hope to add more data and so forth. I will say, and I've had this conversation with our interim director as well. He's not able to be here today, but close to half of the cost of our annual budget is the Rutgers imposed fringe benefit rate and the Institute imposed data core costs. And for those of you who are Institute members, you know about data core. Almost half of our costs are that. We're expecting data core costs to come down quite a bit starting January 1 next year. But we're also expecting the fringe rate to go up next year. We know it will. So we'll see a little bit of a net reduction as the data core costs come down, but fringe remains just a tremendous ball and chain on being able to do this affordably. As I mentioned earlier, the money we're getting from the Department of Health is short term. It's also less than our total annual operating costs. So right now we're operating at a little bit of a loss. We can't do that forever. But all of this means that that creating an affordable fee schedule is difficult. So we follow NIH shared facility core resources guidance on calculating the fee schedule, which means we have to cover our costs, not more, not less. It means everybody has to be charged the same thing unless we find subsidy money, which we do in some cases. There's a little bit of a cart and horse problem here. So the fees, we have a lot of fixed costs. The fees come down when we have more projects, but the fees stay high when we don't have more projects. And of course, high fees are a barrier to getting more projects, the cart and horse problem. We are working through sort of active marketing and outreach to sort of get the word out that this is available. We know it takes time for people to write funds into grants to purchase the data. So we're hopeful that our fee revenue will begin to take off. We've had no fee revenue so far. Last year's cycle was only the DOH money. We'll see what happens this year. And lastly, the statute specifically authorizes us, gives us permission to write grants, and as if we needed that. So we are really eager to raise additional grant resources. And so far we have the DOH and the high probability of the RWJ funds for this year. I'm really eager to hear ideas about other places we might go to support infrastructure, support more pilot work, et cetera. So just to illustrate the impact of the fees, here's Steve's project again. Now he doesn't have to pay these fees. You know, paying $34,000 in fees out of a $40,000 grant would be a little burdensome. DOH is covering that. So the fees for the 4 projects combined about $111,000. So it's costly. And yeah, Steve could write this into a grant, and you know it'll be 2 years before he could then purchase the data from us, because that's how long grants take. So my sort of last implementation challenge is that, you know, I think the absolutely the critical path to building the iPHD and achieving success is to expand the range of data sets that we have. And you saw the list earlier that Jose presented, a couple of new sources that are in discussion to be added. There's a long time lag between the board saying, yes, we want to bring the Medicaid data in or any other data set, and then working through the details with the lawyers, the special statutes that may apply to a given data set. The Attorney General's office is involved. This is a laborious process. But we are very eager to get going on bringing in other high-value data sets that enhance the value of the iPHD. This is absolutely critical path for iPHD success and sustainability. So I will end there and ask these two questions of you. And of course, any other questions you have for us are clearly on the table. So which additional New Jersey data sets do you see as the highest value that you would like to see us investigate for bringing into the iPHD and linking to all the other data we have? And then any ideas about funding and grant sources would be welcome. So I think I'll stop sharing there and we can open it to questions. Yes, Dan, I thought so Dan put in Dan, who is our new the faculty leader of the data course, suggests costs will come down in 2023. That is true, but iPHD budgets are set annually, so we have to wait till our next budget cycle to incorporate those savings. And since we're already operating at a loss, reducing our fees earlier, it's really not in the cards, but thank you. We're looking forward to those cost reductions. Happy to take any other questions, ideas, nominations of data sets. We couldn't have been that clear.
Frank?
Oh, Frank, sorry, I didn't see your multiple hands up there.
Yeah, right, 3 or 4, right. Thank you. That's a fascinating overview. I'm stunned. I was familiar with aspects of this, but Jose's presentation and the complexity of all the matching was an eye-opener squared for me. But the question I have is, Jose and you, Joel, talked about adding Medicaid as a possibility to this, and I'd just be curious. It's a kind of I guess it's a value-added question. If you can get the Medicaid data set, would you think it would increase the attractiveness of the project, by a large amount to outsiders or others and so forth? So it's a little bit, I don't know the specifics of your current data sets, but would Medicaid, would that be a big deal if you can do it?
It would be a huge deal. Huge deal. There are Medicaid data available through ResDAC from the federal level. It's got like 2 additional years of data lag that we don't have. It's not as rich as the data we have. The data sets we have lack ambulatory care information. The Medicaid population is clearly important for the research priorities established by the governing board. I will say, and I see there's an endorsement in the chat from our Vice Chancellor for Population Health. Thank you, Ethan. I would say it's not a done deal that is even feasible to bring in the Medicaid data. The board has endorsed it. So we have our passport stamp to start discussions with Medicaid, which we have done. But the federal Medicaid statute, at least our Medicaid agency interprets it as not really permitting research. Now, you say, oh, but research is done all the time. Well, it's for the purpose of it's analysis for the purpose of improving the Medicaid program, which is, it's not hard to establish that, population health researchers would meet that criterion. But it also means that the Medicaid agency has to review each project, make a determination. It's also their policy to review all products. And it's a real burden on them, frankly. And I would say at the moment, this is a terrible time to be having this discussion because they're completely absorbed in the public health emergency unwinding. So these conversations are a little bit on vacation.
Yeah.
and maybe
Imagine.
restart them again. Anyway, I'll stop there, and I see a couple other hands up. Steve?
So definitely second the motion about Medicaid. I believe that some states have been able to do this in their integrated databases. So that might be possible models to talk about with the state, at least implying that there isn't a federal bar in principle against doing this kind of thing. Some of the other, I hesitated in trying to think of the other data sets because you guys have probably thought about them more than we have and already identified all the reasons why various other data sets can't be done. But just to mention a few, there's the disease surveillance, like the cancer registry. Like cancer is already matched with Medicare at the federal level, the cancer registries. I think there's been various projects to match them with Medicaid, but certainly the cancer registries, if we could get them, would be great. I think on the substance use side, there may be some additional opportunities with data sets like NJSAMS that are the licensed drug provider facilities, but clearly the EMS is interesting because once we get it, they do make the feds do, CDC does make available a national data set with no geography included in it. So that means that folks that would be doing work with the New Jersey data, which correspond to their EMS, their NEMSIS submissions, would be able to have a national comparator, although you can't compare the individual other states. So those are just like a few of the other possibilities that come to my mind that you all have probably thought about more than we have. But clearly Medicaid is the big enchilada, and once we have that, the whole it would be a whole quantum leap in the power of the iPHD.
Yep. Thanks, Steve. So just quickly want to mention that the UB data are Sharif, in answer to your question, is essentially the equivalent of the Sparks, and like the EMS data, there is through AHRQ. There's data from many other states for comparison purposes, where you can't even identify the state. But speaking of other states, Anna, welcome. Thank you for joining us.
Thank you so much. I appreciate being here. So my first job was in the state of New Jersey, but I am currently in South Carolina and work extensively with their data warehouse and the multiple links. So I just want to sort of respond a little bit to how we're able to do it in New Jersey. We have a legislative proviso that requires Medicaid, along with all other state agencies, to contribute to a data warehouse depository. That takes away some of the issues regarding whether the data is being used for purposes of evaluation to enhance the Medicaid program, or it contributes greatly to the population health status and understanding, both for South Carolina, as well to be used by other researchers. And so I would say, to echo Stephen's comments, it is the big enchilada in a state where, for example, 60% of all births are paid for by Medicaid. Not having Medicaid data presents tremendous gaps. So for us in South Carolina, that means that we have the Department of Education, we have corrections, we have the disease registries, we have the Department of Social Services, which allow us to gain an understanding of the connections between children who move into foster care, who then are serviced through the Department of Mental Health, who then are Medicaid or non-Medicaid. It also addresses what I think is a critical area, and that is churn. What happens to individuals who roll off, and what are the implications of that? And because the data is there, it provides us with tremendous strength to understand, in a state that has not expanded Medicaid, issues associated with the uninsured The Department of Housing also contributes their data. I just want to say kudos to the presentation Jose did. We struggled long and hard with those linkages in South Carolina, and just tremendous what that presentation did. So it is possible. We were able to achieve it through a legislative proviso. That takes away all the turf issues. It takes away the individual concerns, and it puts it right back on the advancement of population health and understanding within the state of South Carolina. And we're glad to share if it's helpful about that legislative proviso. And that creates funding because it creates a governing board and a framework for under which that work and that data warehouse is sustained. So I just wanted to share that experience from South Carolina.
Great, thank you. And yeah, I'm well aware of your work. And if anyone hasn't seen the work coming out of South Carolina, take a look. It is just amazing, geographic based, and really rich data. You know, of course, data agencies sharing data, the silos that our agencies live in everywhere, not just New Jersey, is a major barrier to data sharing. The way that's addressed in the iPHD law is that it delegates to the Attorney General's office the determination of whether it's legal to bring data in, which is not as far as South Carolina went, but it avoids the problem of agency lawyers saying, nope, not permitted, end of conversation. And our experience with the AG's office is that they do their due diligence and they're really careful and they adhere to the law as you'd expect. But that's been a real bonus for us. Right now, we only have DOH data, but we'll be branching out in the next year or so. So, and Anna, I'm going to take you up on your offer. Maybe you can bring one of your lawyers with you. So, other questions? Let's see, there was something in the chat. Also from Ethan, endorsing the cancer registry data. And I think that's I mean, there's no low-hanging fruit in this world, but those data are already managed by Rutgers. So it's DOH data, but we will easily start those conversations. We'll see where they go.
One other thing that might be worth looking into is thanks to these wonderful efforts of Joel and Margaret over a period of a couple of years, we have finally gotten to the point where we have a DUA to link prison release data with the iPHD data sets, but that could be a standard linkage within the iPHD as well. So perhaps if the prison and jail release, which is technically public information, could be linked on a regular basis, I think that would be another, then one wouldn't have to go through these very elaborate individual and extremely time-consuming individual DUAs to do those linkages.
Right. Of course, the public nature of the data may raise challenges. If I could look up a record from prison data and identify the individual, you could then re-identify the iPHD data sources. So, but that's why we have, an army of lawyers and data people involved here. So, thank you for the suggestion. Other questions? Well, thank you all. We'll be having continuing opportunities for conversation, both about the technical issues, but also about growing the iPHD. I noticed nobody offered to give us a couple of $1 million, but again, if you have ideas about where we can go for infrastructure dollars, especially, I think clearly this work is fundable with research dollars, and each researcher has to then generate the revenue that could then help support the data sources here. But if you have other ideas of places to go for resources, please let us know. We do want to work on some infrastructure grant proposals. So one last pause for any further questions, and we'll give you back 30 seconds in your day. Okay, thanks everybody. It was great seeing you all.